Hello dear students. Let us begin with the NEET pattern questions 2019. The first image. This is actually, as you can see, is a Terri Geum. So this is a Terri Geum, and Terri Geum, as you know, is a degenerative condition of the conjunctiva. Mainly we have got two degenerative conditions of the conjunctiva. One is the pingicula and another is the Terri Geum. Now, what is the most common cause of vision loss in the patients with the Terri Geum? Whether it is the cataract, whether it's glaucoma, whether it is the obscuration of the visual axis, or whether it is the astigmatism. So if you see here, always this Terri Geum acts as a wing-shaped fold of the conjunctiva over the cornea. Now because it's a wing-shaped fold which is encroaching from the conjunctiva to the cornea, basically it is first pressing the cornea, and that is why the earliest loss of vision which is occurring with the Terri Geum is actually due to the pressing of the cornea, that is due to the astigmatism. Now, what is the type of astigmatism that can occur with the Terri Geum, and what are the other things which can actually decrease the vision in cases of Terri Geum? Now let us see what happens here. Because it is a defect which is coming from the temporal side and it is approaching nasally, basically it is crossing the limbus and it is pressing the cornea from the horizontal side. Therefore, what happens? The vertical curvature is more than the horizontal curvature. Therefore, vertical curvature is more than the horizontal curvature, and that is why this type of astigmatism is what you called as with the rule astigmatism. Therefore, it is called as with the rule astigmatism. So now we know that the most common cause of vision loss which is occurring in the patients of Terri Geum is astigmatism. Not only the astigmatism, we also know that it is actually the with the rule type of astigmatism. Now what do you mean by with the rule astigmatism? As I told you, whenever we have got astigmatism, it is mainly of two types. It can be the regular astigmatism or it can be the irregular astigmatism. Now as the name suggests, irregular means where no definite criteria is followed. But in cases of regular astigmatism, we have got the cylindrical error at least in two meridians, that is M1 and M2. Suppose I take two meridians M1 and M2. Now we have got the cylindrical error, that is your astigmatism, that should be at least in two meridians M1 and M2, and out of these two meridians, one should be the horizontal component and another should be the vertical component. Now in cases of regular astigmatism, one should be the horizontal astigmatism, another should be the vertical astigmatism. We have M1 and M2, plus these should be perpendicular to each other. Now whenever the astigmatism follows these three criteria, we have got two meridians M1 and M2 which are perpendicular to each other, one of which is horizontal and another is vertical, then we can say that it is regular astigmatism. Now after being calculated that it's a regular astigmatism, how to decide whether it is with the rule or it is against the rule? So it's a very simple phenomena how we can decide that whether it is with the rule astigmatism or whether it is against the rule astigmatism. You have to see that which meridian is steeper. If the vertical is more steep than the horizontal, then it is called as with the rule astigmatism, while if horizontal curvature is more than the vertical, then it is called as against the rule astigmatism. So we have got two types of astigmatism, with the rule astigmatism and against the rule astigmatism. Now one thing should have come to your mind, what rule it is with and what rule it is against. It is actually the nature's rule. Naturally also our corneas are more steeper in the vertical plane and they are lesser in the horizontal plane. So when due to astigmatism also it is following this rule, vertical plane is steeper than the horizontal, then it is called as with the rule astigmatism, while when it is going against this rule and horizontal meridian is coming to be steeper than the vertical, then it is called as against the rule astigmatism. So as for this question, the pterygium, because it is growing in the horizontal fashion, as you can see here, it is growing in the horizontal fashion, pressing the cornea hard. Therefore, vertical curvature comes out to be more steep in comparison to the horizontal, and therefore it is with the rule astigmatism. Yes, no doubt, after some time when it will be crossing this pupillary axis, then there will be obscuration of visual axis also. So, earliest as well as most important, these are the two things. The earliest loss of vision which is occurring with pterygium is due to the astigmatism, while the most important cause of vision which is occurring in pterygium is the obscuration of visual axis. Now coming to the next one. The question number 2. Now here you are being shown a instrument see this one. This is an instrument having the multiple rods. You can see a series of rods here, and these series of rods are actually the parallelly arranged glass rods which are having red color, and this is called as what you called as the Murdochs rod. This is called as Murdochs rod. So if you are being asked about the name, actually this contains the series of glass rods, and these glass rods are actually red in color, and the name of this instrument is called as the Murdochs rod. So if you are there to identify this is actually a Murdochs rod. Now what is actually the use of this Murdochs rod? This Murdochs rod is actually used to the diagnosis of heterophorias. Let us see how. This is used for the diagnosis of the heterophorias. Heterophorias. Now heterophorias are same as that of the latent squint. The latent squint. Now how this latent squint is diagnosed? With the help of the Murdochs rod. Now first of all you should know that why actually latent squint is latent, why it is hidden. It is hidden actually because of the fusion. So that means still the fusion is present in the patient, and that is why the latent squint is not manifesting. That means if we try to break this fusion, or we are able to break this fusion by anyhow, we are able to manifest this latent squint. Now let us see how this will help in manifestation of this latent squint. Now what happens? This Murdochs rod, what it will do actually, it will convert a point source of light, into a line. So that means in front of the eye, in whichever eye you are keeping this Murdochs rod, in that eye the patient will see a line instead of the point source of light. Now this is the most important thing. So that means, suppose we have got this test, this is the eyes of the patient, and we are using the Murdochs rod in front of one of the eyes. Now what will happen? The eye from which no Murdochs rod is there, In this eye, the patient will see a point source of light, while in the other eye, the patient will see a line. So there will be dissociation. There will be no fusion, because for fusion we require the simultaneous perception. If you remember, there are three prerequisites of binocular single vision. First is your simultaneous perception, then is the fusion, and third is the stereopsis. Now, when we do not have the simultaneous perception, that means we cannot have fusion also. In order to break this fusion, what we have done, we have kept this rod called as the Murdochs rod in front of it, and what you have to do actually, you have to place this rod in such a way that the axes of these rods are parallel to the axis of the squint. So if you feel that patient has horizontal squint, you have to keep it horizontally. If you feel the patient has a vertical squint, you have to keep it vertically. Now what will happen, in one eye the patient will see a point source of light, while in the other eye the patient will see a line. Now let us see how to do the interpretation of the squint from this Murdochs rod. Now what will happen, the patient is able to see this red dot from the normal eye where there is no Murdochs rod, suppose like this, and in the other eye the patient is seeing a line. Now if the patient is orthophoric, the line and this point source both will be in the same axis because there is fusion. Fusion is present. So if you are getting this kind of view, that means here there is no squint, there is orthophoria. While if you are not getting these two things in a same line, we are not having the dot as well as the line in the same axis, that means there is presence of squint. So first thing, we are able to diagnose the presence of squint with the help of this Murdochs rod. Now let us take the second option. Suppose, so we saw that how in the case of orthophoria, both will be present in the same axis. Now suppose the patient is having the squint and there is heterophoria, we will not get now both these things in the same axis. Now the line that we are getting from the eye in front of which the Murdochs rod was placed, this line can be either in front of this dot or it can be behind the dot. Now how to diagnose this? If it is present in front, that means the patient is having the esophoria. That means the patient is having the esophoria, that is the convergent squint. While if you are getting this line behind, something like this, then in that case the patient is having the exophoria. Now one thing which is important to notice here is whenever you are having the horizontal squint, actually whenever you are having the horizontal squint, in those cases you will get the vertical lines. So if you are getting the vertical lines, that means the patient is having horizontal squint. Now in the horizontal squint we can have two things, we can have eso or we can have exo. So in cases of eso you will get in front out from the outer side, while in cases of exo you will get on the inner side. Now what about the vertical squint, the hyper and the hypo? Let us see. Now if the patient is having vertical squint, the patient will show the horizontal lines. Now what will happen in cases of horizontal lines, actually, suppose this is a red dot. Again, if the patient is not having any squint, what will happen? You will get a line which is in axis with this red dot. That means again the patient is orthophoric, there is no squint. Now if the patient is having the vertical squint, what about that? If the patient is having the vertical squint, what will happen in this case? Now there are two options, either there will be hypertropia or there will be hypotropia. If it is hypertropia, then you will get a line which is below this red dot. This is called as hypotropia. While if you are getting a line which is above, if you are getting a line which is above this, something like this, then this is called as So now what will happen in cases of vertical squint, if you are getting a line which is above this red dot, that means the patient is having the hypotropia or the hypophoria, while if the line is below, that means the patient is having the hypertropia. So again, this is a very important test because it will tell you not only the presence of the squint, but also it will help you to find out the type of squint. It tells you whether the latent squint is present or not. Number one, that means it helps in the diagnosis of hydrophorias. Number two, how it helps in both horizontal squint as well as vertical squint, esophoria, exophoria, vertical squint, hypo and hyperphoria, and the exact manifestations. What will you get if the line is in outer side, that means it is esophoria. If the line is inner side, that is exophoria. If it is down, it is hyper, and if it is up, then it is hypo. So this was the Murdochs Rod test. Now coming to the next one. The third is about the ptosis. Third is about the ptosis. Now, actually, what is ptosis? Ptosis is the most common congenital lid abnormality. It is the most common congenital lid abnormality. And actually, what is ptosis? It is the drooping of the upper eyelid. Normally, the upper eyelid covers about 1/6 of the cornea, that is about 2 mm. So it should be less than 2 mm. But if there is drooping of the eyelid, upper eyelid over the cornea more than the normal, then this is called as ptosis. Now, we can divide this ptosis into 3 types. It can be mild ptosis, or it can be the moderate ptosis, and then third is the severe ptosis. So a very normal classification we can use, whenever the ptosis is 2 to 4 mm, then it is mild. When it is 4 to 6, it is moderate, and when it is more than this, then it is called as severe ptosis. Now, why it is actually important to categorize the ptosis into mild, moderate and severe? Because it is helping us to decide the type of treatment. The surgical plan is dependent upon the type of ptosis. Now, another important thing which is actually helping us to search the type of surgery is the levator function. Levator function. Now, what is actually this levator function? Levator function means the function of the LPS muscle, that is levator palpebrae superioris, and it's very important that whenever you are doing the surgery over this muscles, it should have a good function. Meaning by, if it does not have the good function, then its resection won't help. So what will happen? Depending upon the levator function, you have to decide whether the resection that has to be done of the levator muscle has to be minimal, it has to be moderate, or it has to be maximum. Let us see how. If it is good, or it's fair, or it can be poor. Poor, I can say that it is poor or it is no function of the levator muscle. Now what will happen? How we will decide how much of the levator resection has to be done. Now if it is good, then you have to do very minimal of the resection, that is only 16 to 17 mm. If it is fair, then you can do from 18 to 22 mm, and then for no you can do for 23 to 24 mm. So this is actually the amount of levator resection. What is this? This is amount of levator resection that has to be done in cases of the ptosis depending upon their function. If it is good, we have to do the minimal resection of the muscle, that is 16 to 17 mm. If it's fair, we have to do better than 18 to 22, and if it's no or very poor, then you can do maximal resection, that is 23 to 24. Now how to decide that which surgery to be opted? Let us see. First of all, if you have got only mild ptosis. Now, if the patient is having only mild ptosis and that too with the good levator function. then what to do, which is actually the most common aspect. The most common cause of the ptosis is the congenital ptosis, and in congenital ptosis what we are getting usually is the mild ptosis, and these people have the good levator function also. So that means the most common surgery that we are doing is for this mild ptosis along with the good levator function, and here we are doing what you called as fascinella cervet surgery. This is called as fascinella cervet surgery. Now actually what we are doing in this fascinella cervet, it is a very frequently asked question, the surgery of choice for the mild ptosis with the good levator function. What we are doing, we are everting the upper eyelid here, and here you are also getting a tarsal plate. Now what is happening, to this tarsal plate is attached the muscle. This muscle is actually the Muller's muscle. So a Muller's muscle is actually attached here. So what we have to do here in cases of this surgery, we have to do the resection at 3 places. You have to do the tarsal resection also, then you have to remove this Muller's muscle also, and then you have to do the conjunctival resection also. Therefore it is called as tarso-conjunctivo-mullerectomy. So what we do, we are doing the resection of the upper end of the tarsal plate along with this Muller's muscle along with the conjunctiva. So this is what you called as fascinella cervet surgery. Now what are the other things that we can do? The other thing that we can do is the second one, that is your levator resection. Yes, the levator resection can also be opted in the patients if the ptosis is not mild. Now what will happen if you have got mild to moderate ptosis? If the patient is having mild to moderate ptosis along with mild to moderate ptosis along with good or the fair levator function, then in those cases we can do the levator resection. How much amount of levator resection, that we have already discussed here, that you have to do with 16 to 17 in cases of good levator function. You have to opt for 18 to 22 mm for the fair one. Now you will see that I have left this one. Why I have left this? I have not opted here for the poor levator function because here the resection is contraindicated. You don't have to do the levator resection if there is poor or no levator function. So what you will do in those cases? If it is there, then what we can opt for? Then we have to do the another thing that is called as the frontalis sling operation. Frontalis sling operation. Now what is this frontalis sling operation? As the name is suggesting, what we are doing, we are tucking actually here, we are tucking the upper lid to the frontalis muscle. This is also acting as the elevator of the eyelid. So what we can do, because the levator function is not good, so we have to rely now on the frontalis muscle. So what we can do, we have to tuck this upper eyelid to the frontalis muscle, and we require something. So for that we have got this sling. With the help of the sling. Now how can we make this sling? We have got two options for making this sling. Either we can use the facial atta, we can use a natural material, that is facial atta, or we can use some artificial man-made materials also, where we have to use the non-absorbable. Or we can use some non-absorbable materials. Obviously you have to use the non-absorbable materials, because if you are using the absorbable materials, the benefit of surgery will go after it is absorbed. So you can do the frontalis sling operations, then we can do the levator resections, we can do fascinella cervet surgeries, and if they ask you the most common surgery that is being done, then it is the fascinella cervet. But if they are asking you that a patient is having moderate ptosis, severe ptosis, no levator function is there, poor levator function is there, in that case you cannot do this fascinella cervet, you cannot do the levator resection also. In those cases the answer will be the frontalis sling operation. Now the other important thing, how to diagnose, how to prescribe the spectacles, and how to assess that whether this spectacle prescription is with the rule astigmatism, it is against the rule astigmatism, it is simple astigmatism, it is compound astigmatism, and whatnot. So let us take a very crisp and quick review of astigmatism with respect to these things. Now, very quickly, let us see what is astigmatism. Astigmatism. Astigmatism means the cylindrical error. This is actually a cylindrical error where we have got the refractive error at least in two meridians, that is one horizontal meridian and another is the vertical meridian. So, contrary to the spherical errors where we were having the same amount of refractive error in all the planes, in cases of astigmatism we are having different error in at least in two meridians, one in horizontal and another is vertical. Now, most of the cases we are taking as regular astigmatism, that they are perpendicular to each other, while the case may not be in cases of irregular astigmatism. So now, due to this toric surface, because astigmatism is occurring due to toric surface, due to the irregular surfaces, we can divide this astigmatism into two. As I told you before also, it is regular and it is irregular astigmatism. Irregular astigmatism, like for example, we have keratoconus. So whenever there is irregularity in the surfaces where the refraction has to take place, what are the four refractive surfaces? We have anterior surface of cornea, we have posterior surface of cornea, anterior and posterior surfaces of lens. So whenever these things are actually irregular, we can have astigmatism, and that kind of astigmatism is the irregular astigmatism. Now, what is regular astigmatism? As I told you just now, that here we have got again the refractive error that is different in two meridians, that is M1 and M2. We can take them as M1 and M2, and one of them has to be horizontal, another of them has to be vertical. It can be either of them, any one of them can be horizontal and any one of them can be vertical, and plus they should be perpendicular to each other. Then we can say that it is the regular astigmatism. Yeah. Now this was first concept of regular and irregular. Then we discussed one more thing, that was the with the rule and against the rule astigmatism. Now what was that? Now whenever you are having the astigmatism in two meridians, one of which is horizontal, another is vertical, both are perpendicular, now only one thing more can be there. Either vertical is more than horizontal or horizontal is more than vertical, means which plane is more steeper. Curvature is more, that means which plane is more steeper. So if vertical plane is more steeper, then it is with the rule astigmatism, and while horizontal plane is more steeper, then it is against the rule astigmatism. Now, when I can say that it is simple, when I can say it is compound, and when I can say that it is mixed. Let us see this. Now let us see what is simple, what is compound, and what is mixed. Now simple means, as the word say, it is simple. Simple means when only one meridian is involved, either M1 or M2, either of the meridians is involved. It can be a horizontal meridian, it can be a vertical meridian. So when only one meridian is involved, it is simple, as the name indicates. Then what is the meaning of compound? Compounds were the elements also. Compound always means two. So that means whenever two meridians are involved, means both M1 and M2. Now look at the difference. Here either of them, simple means either of one meridian is involved, either M1 or M2, while compound means both. So here I will write either, and here I will write both. Okay. Now what will happen when it is involving only one meridian, either horizontal or vertical? Now what will happen? That means in other meridian there is no refractive error. When in another meridian there is no refractive error, that means the patient will have plane. So in one meridian there will be error, and in another meridian it will be plano lenses that will be used. While here we will use the lenses in both the meridians, right? Now the refractive error that is present in either of the meridians, horizontal or vertical, it can be either minus or it can be plus. That means either it can be myopic in that plane or he can be hypermetropic in that plane. So now if you catch a back, if it is minus, then it is myopic. If it is plus, it is hypermetropic. That means if the patient is having the plane lenses or he is having the plano glasses in one plane and he is having a negative cylindrical error in other, then that means that he is having simple myopic astigmatism. While on the other hand, if he is using the plano in one and he is having the plus correction in other, then he will be having simple hypermetropic. So minus with plane or plus with plane. This is simple astigmatism. So for example, if you are getting, for example, let me give you one example here. Suppose the patient is coming to you with -2 diopter cylindrical at 90 degree. So he is having only one refractive error in only one plane, that is in 90 degree. That means it is simple. He is having -1, that means it is simple myopic. If it was plus, then it will become hypermetropic. Now on the other hand, when the patient is having the refractive error in both the meridians, M1 and M2, both horizontal as well as vertical, then also either he can be having minus in both the meridians or he can be having plus in both the meridians. Means in both the meridians the patient is either myopic or in both the meridians patient is hypermetropic. So now I can say the patient may be having compound myopic astigmatism or he can be having compound hypermetropic astigmatism. Now what is the difference between the two? The difference is that in simple one is plane, other is minus or plus, while in compound in both the meridians it is minus or in both the meridians it is plus. Now this was simple till now, even in compound it was simple, but now the problem comes when it is the third one. Let us see what is that. It is the mixed one. Now what does this means, mixed? The name itself is saying that it is mixed. That means here again both the meridians are involved, that is M1 and M2, but because they are mixed, so one is minus and one is plus. Either of one can be minus and either of them can be plus. So it can be mixed astigmatism, it can be simple myopic, simple hypermetropic, compound myopic and compound hypermetropic astigmatism. So we can classify them as simple myopic, simple hypermetropic, compound myopic, compound hypermetropic along with the mixed astigmatism. And as far as clinical picture is concerned, you will have the least symptoms. Again a very important MCQ, we will have the least symptoms in what you called as mixed astigmatism. In cases of mixed astigmatism, we will have least symptoms. Now after combining all these concepts, let us see how to tell whether it is mixed, whether it is compound, whether it is simple, with the rule and against the rule. So let us take some examples. Now suppose we are taking this example. The first is +3 diopter at 90 degree and +5 at 180 degree. So if you see here, can you tell me what type of astigmatism it is? See, here both the meridians are involved, therefore it is compound, yes, easy. And both are plus, therefore it is hypermetropic astigmatism. So I can say that it is a compound hypermetropic astigmatism. Now other thing which they can ask, whether it is with the rule or it is against the rule. So let us see how to define this. Now to define this, whether it is with the rule or whether it is against the rule, you have to find the retinoscopic findings. Now other thing which is important is that the error will always act, the power will act always perpendicular to its axis. So the +3 which is at 90 degree will actually act at 180 here, while the +5 which is at 180 degree will act at 90 degree. So here we have +5. So this will be the findings. Now in order to find whether it is with the rule or it is against the rule, so this is vertical and this is horizontal, you have to find whether vertical is steeper or whether horizontal is steeper. So it is lesser the plus, more is steeper. Lesser the plus sign, lesser is the power of plus sign, more steep it would be. So I can say now, therefore horizontal is steeper here. Therefore horizontal is steeper. Therefore it is against the rule astigmatism. Let us see once more, because here it was plus 3 diopter at 90 degree. Therefore the power will act perpendicularly and this will come at 180 degree, while plus 5 is at 180 degree. Therefore this power will act perpendicularly at 90 degree. So we have plus 5 here and we have plus 3 here. Now out of plus 5 and plus 3, which one is more steeper? It is plus 3, because lesser is the power of plus sign, more steep it is. Therefore I can say the horizontal one is more steeper. Horizontal is more steeper means it is against the rule astigmatism. Let us see one more example here. Suppose we have got other thing. This is the example number 2. For example, we have plus 3 diopter cylinder at 90 degree and we have got minus 5 diopter cylinder that is at 180 degree. Now how will you assess this? Now because here both the meridians are involved, therefore it is compound, yes, therefore it is compound astigmatism. One is plus and another is minus, therefore it is mixed. So I can say now that it is a mixed astigmatism because it is involving both the meridians. If they were same, if either of them were plus, then it would have compound hypermetropic. If either of them were minus, then it would have been compound myopic. Now because they are different, one is plus, another is minus, therefore it is not compound, therefore it has shifted to the mixed astigmatism. Now let us see whether this mixed astigmatism is with the rule or it is against the rule astigmatism. So let us draw the retinoscopic findings. Plus 3 is at 90 degree, therefore its power will act here, plus 3 diopter, and minus 5 at 180 degree, therefore it will act perpendicularly, so therefore minus 5 here. Now out of the 2 plus, lesser was the plus, more steeper it was, but out of the minus and plus, it is the minus which is more steep. It is minus which is more steep. Therefore I can say that vertical curvature here is more than the horizontal and therefore it is with the rule astigmatism. So this is how you can find out whether it is with the rule astigmatism, against the rule astigmatism, simple, compound and the mixed astigmatism. Now see this figure. This is a figure coming from the X-ray orbit. This is a figure from the X-ray orbit and this is actually showing the fracture floor of the orbit, and it is actually the most common wall also which is to be fractured in cases of the blunt trauma. So whenever the patient is suffering from the blunt trauma, the most common wall which has the maximum risk of being fractured, that is the inferior wall. And how we can diagnose it? We can diagnose it actually on the X-ray. This X-ray orbit is done and the view. What is the view to be taken? The fracture is called as the blowout fracture. This fracture is called as the blowout fracture, which is occurring due to the blunt trauma. This is occurring due to the blunt trauma, and the orbit has the 4 walls. The 4 walls, that is the medial wall, the lateral wall, the superior wall and the inferior wall. And out of these 4 walls, the thinnest wall is this medial wall, while the thickest is this lateral wall. While the fracture is most common in cases of inferior wall, and this is called as the blowout fracture. Now we can diagnose this fracture by the X-ray orbit, and the view is called as the Waters view. Another important question is the view in which it is diagnosed. It is the Waters view, and what is this sign called as? The name of the sign which you are getting on this Waters view is called as the teardrop sign. This is called as the teardrop sign, Now, what are the other things that you will get in this blowout fracture? How the patient will manifest clinically if the patient is having this blowout fracture? Let us see the clinical features. The patient who is having these blowout fracture will first of all present with the periorbital edema. Now, as soon as there is a fracture, there will be edema in the peripheral area, and this area which is near the floor of the orbit will be involving the valve also. Will be involving the nerve also, and this nerve is what you call as the inferior orbital nerve. So, therefore, there will be decreased sensations. There will be decreased sensations in the area which is supplied by the inferior orbital nerve. We will have periorbital edema also, we will have decreased sensations also, then we can also have the emphysema of the lids. Then due to the mechanical entrapment of the tissues, mind you, this is not a true paralysis, it's a kind of restrictive squint that we are getting due to the entrapment. This is called as the entrapment of the soft tissues. Due to this entrapment, we are getting what you called as the restrictive squint, and due to this restrictive squint, the patient will have diplopia. Obviously, the patient is having the incomitant kind of squint, because restrictive squint is an incomitant type of squint. Therefore, this patient will also show the diplopia. But this is not a true diplopia. This diplopia is not a true diplopia, and therefore here the patient will get forced duction test positive. There will be diplopia in both the gazes, both in upward gaze as well as in the lowermost gaze. So there will be entrapment of the soft tissue structures, then there can be restrictive squint will lead to diplopia, and there will be forced duction test positive. Now, another important thing about this blowout fracture is that it will manifest in both the forms. That is, it can present both as proptosis also, as well as in the form of enophthalmos also. Now, this is again amazing, because the same thing is leading to both exophthalmos and enophthalmos, both proptosis and enophthalmos. Let us see how. Proptosis is in the acute cases when there is so much of edema present, and that can lead to actually the bulging of the eye. So in the acute cases, after some days, the patient can show the proptosis. But in the long run, if you see, due to the entrapment of inferior rectus, especially due to the entrapment of inferior rectus, it will pull the eyeball backwards, because there is fibrosis also, plus because it's the entrapment of inferior rectus, it is not able to let this muscle work. So that will also pull back the globe back. So due to that, in the long run, the patient can have the enophthalmos also. So the patient can present with the subconjunctival hemorrhages, the ecchymosis, the emphysema, the periorbital edema, the decreased sensations, then forced duction test positive, both in upward gaze as well as in the downward gaze, as well as both the proptosis as well as enophthalmos. And whenever we suspect this, we will be doing this X-ray orbit, especially in the water's view. The patient will stand in such a position as if he is drinking water. Whenever we want to take the film of the inferior wall of the orbit, it's always best that we take the view in the water's view. Now the treatment concern. Treatment, yes, you have to do the surgery. It may require surgery, but the thing which is most important is the surgery should be done at least after 10 days. Or you can even prolong to 14 days also, means you have to wait till 2 weeks, wait for 14 days, let the edema subside, let the dust settle, and you may actually get whether it was actually the paralysis, whether it was a true diplopia, true squint, or whether it was all due to entrapment, which will get back when the edema subsides. So always wait for the surgery till 14 days. Now the next one, the anti-glaucoma drug. The anti-glaucoma drug which is avoided in the asthma. As I always say, it's a must In every PG entrance examination, anti-glaucoma drugs are an important topic, and every year you get a question from this. Anti-glaucoma drug which should be avoided in asthma. So it is actually the non-selective beta blockers. The non-selective beta blockers. Now beta blockers were once the drug of choice in the primary open angle glaucoma. Now they are not. Let us review what was their mechanism of action, because these beta blockers are actually acting on the beta receptors, and the beta receptors are actually responsible for the secretion of aqueous humor, and therefore what will be the mechanism of action? They will lead to decreased aqueous secretion. So obviously they will be very effective because they are acting directly on the aqueous production. See, we can help glaucoma in two ways. Either we are reducing the secretion or we are increasing the drainage. When we are decreasing the secretion, it is obviously more effective. So the beta blockers are actually acting on the aqueous production. It is decreasing the aqueous secretion. We can have two types of beta blockers. One, we have got non-selective beta blockers, and another is the selective beta blockers. The non-selective beta blockers, the most popular one is the Timolol, and Timolol 0.5% BD is actually still the most popularly used drug nowadays. Even when it is not the drug of choice, still we are using this Timolol as the drug of choice. Very convenient, very effective, but the only problem is the limitation in some cases. Now where it is avoided, or better, it is contraindicated. It has to be contraindicated in the patients having the cardiopulmonary diseases. In the patients having the cardiopulmonary diseases, those patients who are having cardiopulmonary problems, it can be bronchial asthma, it can be bronchiectasis, atherosclerosis, hyperlipidemias, coronary artery diseases. In those cases, it's better to avoid these non-selective beta blockers, and in those cases what we can do, if you want to give the beta blockers only, what we can do, we can give the selective beta blockers. For example, we have got the bitoxolol. So in those cases we can give the bitoxolol. Otherwise Timolol is a very good drug. So the drug that has to be avoided in the patients of the bronchial asthma is actually the non-selective beta blockers, or specifically speaking the Timolol. Coming to the next one now, the triad of toxoplasmosis. Toxoplasmosis is again important. It can occur congenital way as well as in the acquired way, and I always tell you the triad of congenital toxoplasmosis. C for congenital, as I always say, C for congenital consists of three more C's in its triad, and the first C is the convulsions. And why these convulsions are taking place? It was due to the hydrocephalus. Then we have got another C, that is your chorioretinitis. So we have another C, chorioretinitis. Just to remind, chorioretinitis is nothing but the posterior uveitis, and then we have got the third C, that is calcification. Now this calcification is actually taking place in the brain. So it is the intracranial calcification. So if you see, it is actually the convulsions which can also present with the congenital cataract. Another thing which is occurring in these patients who are having congenital toxoplasmosis, they can have cataract also. So I can say the convulsions with cataract can be a patient of toxoplasmosis, but it can be a patient of galactosemia also. So whenever you are getting a question on cataract with convulsions, don't get confused with toxoplasmosis. The first provisional diagnosis in those cases will be galactosemia and not the toxoplasmosis, because to diagnose the toxoplasmosis, the must thing is the triad. So if you have chorioretinitis also, if you have calcification also, then only you should go with the toxoplasmosis. And I cannot leave this because it is utmost important, the headlight in the fog appearance. In cases of the acquired toxoplasmosis, the one thing which is very, very important is the headlight in the fog appearance. So this headlight in the fog appearance, because we are having a patch of chorioretinitis which is appearing in the vitritis. So fog is the vitritis, headlight is the chorioretinitis. So that is actually compared with the headlight in the fog appearance, and it is again a very hallmark feature which leads to early macular involvement in cases of toxoplasmosis. Now another triad that is important here is the triad of the congenital rubella. Another important thing which is occurring in the newborns at birth is the congenital rubella syndrome, as it is a part of the TORCH group of infections, and TORCH group again are very common in India, and that is why we have started giving even this rubella vaccine in the, we have started giving this rubella vaccine even to the adolescent females, so that by the time they come to the reproductive age group they are already immunized, and therefore they have little or no risk of having this maternal rubella, because maternal rubella is not only a component of TORCH group of infections, but it's a most important and most severe cause of the congenital cataract. Now what is the triad of this congenital rubella? Because it's a syndrome, it is involving multiple organs. We have got eye, we have got ear, and then we have got heart. So this is actually a triad. The triad is according to the organs. It is involving eye, it is involving ear, and it is involving the heart. Now the most important components of the respective parts, like for example, if we have eye, we have the congenital cataract here. It can lead to congenital cataract. Then we have salt and pepper retinopathy, salt, pepper, retinitis, and then also the micro-ophthalmos. So these are again very important MCQs. They can be asked separately also. It can be a cause of congenital cataract as a DD of salt and pepper retinitis, as well as the DD of micro-ophthalmos. Now what about the ear? In the ear it is having sensorineural type of hearing loss. Again they can ask you separately what is the type of hearing loss that can occur in congenital rubella syndrome. And then third is the heart. In the heart we are having the most common feature that is called as PDA, that is patent ductus arteriosus. So I can say specifically the triad will be congenital cataract, the sensorineural hearing loss, as well as PDA, or if they are asking you with respect to the organs, it will be eye, it will be ear, and it will be the heart. If they are asking you the most common heart defect, then answer will be PDA. Now what are the other heart defects which can actually occur in cases of congenital rubella syndrome? Let us see those. The other heart defects which can occur in the patient can be VSD, that is ventricular septal defect. Then the patient can also have pulmonic stenosis. Then what is not found in patients of congenital rubella syndrome is the atrial septal defect, that is ASD. It is never found. So there are various forms of questions that can be put up, and the most common one which have been asked twice here this year, that is the triad of congenital rubella syndrome, the eye, ear and heart, the congenital cataract, the sensorineural hearing loss, as well as the PTA. Now coming to the next one, the esotropia. Esotropia is associated with, whether it is associated with myopia, or it is associated with hypermetropia, or it is associated with the presbyopia, or it is associated with the astigmatism. Now what will be the answer? Now let us first define this esotropia. Eso means inward and tropia means the manifest squint. Phorias are the latent squint, while tropias are actually the manifest squint. So I can say eso means the convergent and tropia means the manifest. So I can say now that it is a convergent type of manifest squint. So that means it is a type of squint which is not occurring due to paralysis, rather it is occurring due to a refractive error. Therefore it is a type of the comitant squint. Therefore it is a type of comitant squint which is occurring due to uncorrected refractive errors. Now where you will get this esotropia, where the patient will have a problem in viewing the near things, so that he will try to converge more. When he will try to accommodate more, he will converge more, and therefore he will have the convergent type of accommodative refractive squint. Therefore the answer will cannot be the myopia. Answer cannot be presbyopia. Answer cannot be astigmatism. So our answer will be hypermetropia. Those patients who are having high degrees of hypermetropia, they have blurred vision for the near objects. They are always trying to accommodate more. When they are trying to accommodate more, they are converging more. And when they are converging more, they have a tendency or they have a risk factor predisposing towards the esotropias. Now coming to the next one, that is your IV mannitol. The use of IV mannitol. We all know that IV mannitol is a osmotic drug, and being osmotic drug, it is basically used in the emergency. So it is a very popular and very common drug which is used in the casualties because it's emergency of actions. The emergence of action is very, very fast, and whenever you want a quick relief, we use this mannitol. Now what it will do, and here because it is creating a osmotic gradient and therefore drawing out the water from the places where it is used, therefore how and where we can use. So the first indication where we can use this mannitol is your raised ICT. Whenever the patient is having raised intracranial tension, whenever the patient is having the raised intracranial tension, it can be due to space occupying lesion, it can be tumor, it can be trauma. The first thing that where we use the IV mannitol is the raised ICT. Then the what else? The other places where we can use is the acute congestive glaucoma. Acute congestive glaucoma again is an ophthalmic emergency, and whenever you require the sudden decrease in the intraocular pressure, one of the first drugs that we use is the IV mannitol. What it is doing? It is decreasing the vitreous volume. It is decreasing the vitreous volume. How? Because it is creating osmotic gradient so that water is coming out from the vitreous into the blood. Now because it is leading to the collection of the water from the vitreous to the blood, therefore it should be avoided in the patients who are having the heart diseases or the patients who are having renal diseases, because it can lead to fluid overload, and plus it can also be used in the conditions of renal failure where the kidney is not working. We can give the mannitol. So according to the order of priority, it has to be used in raised ICT, the acute congestive glaucoma, and then for the renal failure. According to the options, we can choose which one to go with. So in this present scenario, amongst the present options which were given, the answer will be the acute congestive glaucoma. Now coming to the other question, that is your ocular features. The ocular features of myasthenia gravis. Ocular features of the myasthenia gravis. Myasthenia gravis is a condition where there is a fatigue of the voluntary muscles. So because there is a fatigue of the voluntary muscles, therefore it is leading to most commonly the ptosis. And these ocular features are present in about 50% of the patients, and I can say that one of the most common or the earliest clinical features in cases of myasthenia gravis are these ocular features. In about 50% of the cases, they are the presenting signs and symptoms. So we have ptosis, then after ptosis we also have what you called as the diplopia. And slowly and gradually it will be involving all the extraocular muscles. When it is involving all the extraocular muscles, it can even lead to the palsies, and after the palsies, therefore it can lead to the squint. So if they are asking what are the most common ocular feature of the myasthenia gravis, whether it is ptosis, diplopia, it is legophthalmos, exophthalmos, inophthalmos, then the answer will be what you call as ptosis. Ptosis is actually the most common feature, and in fact ocular features are the most common features which are the presenting signs and symptoms in about 50% of the cases. Now coming to the next one, the something about the glaucoma valves. The glaucoma valves. Though they are not in much use nowadays, but still because of the question. Now these valves are actually used when even the filtration operation or the filtration surgery, that is the trabeculectomy, has failed. This is the ultimate surgery that we can do in the patients of glaucoma, the trabeculectomy surgery. Now if this surgery fails, then what we can do? Then what we can use is these glaucoma valves, and what we do is actually we apply a shunt. This is actually acting as a shunt. A plastic or a steel device is kept in the bleb, and this bleb is present in the superior temporal area, and this is actually acting as a connection between the anterior chamber and the subtenon space. So this is actually what you called as the sit-on surgery. The sit-on surgery, and though it's not very popular nowadays, we can do this, and these shunt surgeries can be walled also, they can be unwalled also. Most commonly we use the walled ones in order to maintain the unidirectional flow of aqueous humor. So if we feel that our bleb is not remaining patent, the passage that we created between the angle of anterior chamber and the subtenon space, what we can do, we can apply this device so that it can remain intact, and these surgeries are called as sit-on surgeries. One of the earliest valves that was used in India was the Ahmed glaucoma valve. It was the Ahmed glaucoma valve. Then another thing is the regimen of the chemotherapy in cases of retinoblastoma. What is the most popular scheme of drugs that we are using for the retinoblastoma? The most common regimen that we are using in the patients of retinoblastoma is the VEC regimen, and this VEC means the vincristine, then we have the etoposide, and then we have the carboplatin. This is the most popular, and though we can use any two also out of them, but if they are asking you the whole 3-drug regimen which is used for the chemotherapy, and chemotherapy is mainly the drug of choice, it is the treatment of choice in cases of the bilateral retinoblastoma. Whenever the patients have bilateral retinoblastoma, the treatment of choice there is the chemotherapy. While in cases of unilateral retinoblastomas, especially in the advanced cases, it was enucleation that was the treatment of choice. So this is again a very important point. In the unilateral advanced cases, it is the enucleation which is the treatment of choice, while in bilateral cases, it is the chemotherapy. In the chemotherapy, it is the VEC regimen that is most commonly used, the vincristine, the etoposide, and the carboplatin. Now, other question is, they are asking you to identify the test. If you see here in the first picture, both the eyes are open and there is a squint. In the other one, they have occluded one eye. Now the name of this test is cover-uncover test. How to do this test? We have covered one eye with the help of occluder. Now you see, as soon as we have covered this eye, the eye under the cover will go into the deviation, while the other eye, which was under the squint, has taken the central fixation. So the moment we cover one eye, we have broken the simultaneous perception, and because now the simultaneous perception is broken, there is no fusion. When there is no fusion, therefore the latent squint will manifest, and the eye under the cover now will deviate towards the side of squint. Now we will not know this because the eye is under the cover. How can we come to know? When we uncover it. So as soon as we uncover this eye, the eye which has taken the deviation will move towards the opposite direction, so that it can again take the central fixation. So if it was in the convergent squint, it will move outwards. If it was in the divergent squint, it will move inwards. So when we cover the eye under the cover will take the deviation, while the other eye will take the central fixation. As soon as you uncover it, you will see the eye again moving in the opposite direction to take the central fixation. So, by this cover and cover test, again not only we can diagnose the presence of the latent squint, we can also tell the type of squint, and somewhat we can also tell the amount of squint with the help of velocity with which it is coming again to take the central fixation. Thank you.